Now I'm going to my talk. This is about cervical disc prosthesis. I'm going to discuss indication and contraindication. If we go back to the early stages, back late in the 2000s, the rationale for disc replacement was based on the rationale for cervical surgery from the anterior side of cervical surgery in general, mainly for in case of neurologic impingement, either radiculopathy or myelopathy associated to some kind of anterior compression, here the disc. So if we have this combination of neurological signs, any type, and discal origin, then there is a rationale for disc arthroplasty. Initially, there was very few exclusion criteria, something very general as pregnancy, former infection, rheumatoid arthritis, those classical contraindications for implantation in orthopedy in general. Then, a few years later, appeared some contraindications, like multiple level, prior fusion, adjacent fusion, or any type of systemic disease, even HIV, we can see here. And that's only based on the exclusion criteria of the FDA trials. And there is some kind of confusion between inclusion-exclusion criteria for FDA trials, that are scientific investigations, and indications. Therefore, little by little, it happened to be real that most surgeons were not very satisfied with these restricted indications. And this survey from 2012, about 1,500 members of AOSPINE from many countries in the world, showed us that why not doing adjacent segment to a former fusion? Why going into myelopathy? There is some questioning about myelopathy. So the impression is that these criteria are too much restricted. And we have papers from the 2010s. Here is a French paper about multiple level patients. And it shows that those multiple level patients have favorable results compared to one level patient, even 3 level or one case of 4 level patient. On this topic, in this focus, this idea was reinforced by this meta-analysis, and most papers show that there's absolutely no problem using multiple levels. Here is an example of my cases. It's a 2-level discopathy, C5, C6, C6, C7. We went to a double-level disc arthroplasty, and that was fine with some restoration of lordosis. But what I want to say is that, and probably the viscoelastic prosthesis with the ability of binding vertebrae together is a warranty of stability, and there's no point in avoiding multiple levels. This recent paper is a good summary of the situation, showing that it depends on the countries. So if we go on the left, it's the classical contraindications from the US based on the FDA trials. And on the right, here in the middle is what's going on in France, and on the right in Brazil. And we see that the US, there is a concern about multiple level previous surgery, adjacent fusion. Now, for France and Brazil, there's no contraindication regarding these issues, but it's more the stenosis and the myelopathy, which is questionable. So that leads us to the concept of expanded indication in reference to the US restriction. Multiple level, we discussed that already. The hybrid surgery, meaning a combination of ACDF and disc replacement, is another concern. And this paper is about anterior surgery with a group of patients with only ACDF, multiple level ACDF, and another group of hybrid patients with at least one arthroplasty, might be on top of the others or bottom or the middle level, whatever. But these two groups have maybe the same results at follow-up with the improvement of the neurological signs and the neck pain. This is a case of mine to illustrate the situation. We have a 3-level degeneration with not myelopathy here, but some stenosis in the foramen. And I went to corpectomy with a fusion to remove bone because the 2 upper levels seem to me to be too much degenerated, but the bottom one was not so bad, and I went to a fusion. So this is an example of a combination of fusion and disc arthroplasty at the same day surgery. The question of the myelopathy is raised on this German paper, though, with the inclusion criteria of clinical symptom of myelopathy with long tract symptoms associated to symptoms on the MRI with the change of the signal of the medulla on the MRI. And the results of this paper shows improvement of the Japanese Orthopedic Association score from 10 to 15. And that's a good example of what we have for the surgery of spinal canal stenosis, if it's from the anterior approach that the stenosis occurs with arthroplasty. That's a case of mine of stenosis with the myelopathy. There are 3 levels involved here. On the right is the lowest level, and we have a severe myelopathy with hypersignal and a severe degeneration. So I did some fusion for the 2 bottom level and the disc arthroplasty on the top level, and that's highly possible. That's why some authors, with all these possibilities, advocate the rationale of using the arthroplasty in most cases. I mean, as much as possible, if it corresponds to the situation. And I could say that I belong to this category. And in this case, they go up to 75% of their case using arthroplasty. The other ones, except the problems of deformity or ineligibility, it's about 15% of their case. They still use ACDF for 15% of their case when the anatomy shows too much degenerated disc, like a very, very small range of motion. In this discussion, it's about 2 degrees, and a very small disc 8 in their discussion is below 3 millimeters. So in that case, the degeneration appears to be too much severe to make an arthroplasty usable, and that's the only case for them for using ACDF. Otherwise, they are fully users of arthroplasty. And this, I have to say that I share this point of view, specifically when we see that long-term studies regarding disc arthroplasty at the cervical spine shows an advantage of arthroplasty over ACDF in terms of results, reoperation rates, and even cost effectiveness in some countries. And that's pretty highly proven in the long-term studies. So in a summary, we see that the indication increase little by little because there is very few situations when we cannot use it in arthroplasty. So in my opinion, worldwide, there is, even if we can keep on the side the regulation, we just use the prosthesis on multiple levels. We can use it at a level adjacent to a former fusion with no specific problems. The remaining problem is the excessive degeneration when the disc is absolutely non-mobile, almost fused. Then I have to say that I keep fusion as a surgical solution. Local instability remains in the basket of the contraindication, but there is very few literature about this, and we understand that instability is not a combination for the arthroplasty, but we can maybe think that the viscoelastic arthroplasty that bind together the vertebra could be a key, maybe used for instability. That's a hypothesis. And finally, the remaining huge non-indication is the isolated neck pain, which is always striking to me because the indication for lumbar prosthesis is back pain. So it's absolutely the contrary in the lumbar and in the cervical. So maybe in the future, this consideration may change. But what I want to finish on, this because we are discussing in very detailed indication and contraindications of cervical disc arthroplasty, while most surgeons in the world still use ACDF as their primary indication for anterior cervical spine surgery, mostly based on the access of the arthroplasty. Well, thank you very much for attention, and I'm available for any question in the field. Thank you very much.